You know that feeling? You touch something maybe like a new soap or some jewelry, and pretty soon after, your skin just feels off.
Yeah, that itch starts,
Yeah.
maybe some redness.
Yeah.
It just doesn't feel right.
Exactly. We touch so much stuff every day,
Yeah.
right? But what's actually going on when our skin reacts like that?
Well, that reaction you're talking about, that's often contact dermatitis.
Yeah.
It's incredibly common.
And that's our topic today. We're diving deep into your revision notes on contact dermatitis. These notes are basically our map for this discussion. You've pulled together all the key info, and our mission, really, is to unpack it all. We want to pull out the high-yield stuff, make it super clear, super memorable for you listening, whether you're actually revising or just want to understand it better. We'll go through your notes section by section.
So like a plan.
Yeah.
And the core idea is pretty straightforward. Contact dermatitis is skin inflammation from touching something external. Your notes really nail the two main types we need to get our heads around. Irritant contact dermatitis, ICD, and allergic contact dermatitis, ACD. We'll break down, what's different, what triggers them, how they look, how you figure out which it is, and crucially, how you manage it.
Okay, perfect. Let's jump right in then, starting with the basic definition you've got in the notes.
Okay, so the core definition you have is localized skin inflammation from direct contact with irritants or allergens, kicking off an immune response. That localized part from the contact, that's really key.
And you mentioned those two main types, ICD, the irritant kind. That's the more common one, yeah.
Yeah, it is. And it's non-allergic. You don't need to have encountered the substance before. It's more like direct damage to the skin cells.
Ah, okay. So things like harsh soaps, detergents, maybe weak acids or alkalis, stuff that just physically or chemically irritates the skin.
Exactly. Direct damage. Now, ACD, the allergic type, is a bit different. It's a delayed type 4 hypersensitivity reaction.
Okay, hypersensitivity. So that means the immune system's properly involved.
Right. It needs prior sensitization. Your body has to have met that specific allergen before, remembered it, and then the next time you touch it, boom, delayed immune attack.
Gotcha. And your notes have this brilliant example that kind of bridges both. Cement.
Oh, yeah. Cement's a classic. It can cause both ICD and ACD.
How does that work?
Well, it's alkaline, so it's directly irritating. That's the ICD part. But it also contains things like chromates, which people can become specifically allergic to. That's the ACD.
Wow. Okay. One substance, two different ways it can get you. Your notes mention other types too, like occupational, phototoxic.
Yeah.
But the main focus for revision should be ICD and ACD.
Definitely. Those are the core mechanisms. And speaking of occupational, your notes rightly flag that occupational contact dermatitis is actually the most common work-related skin disease.
Really? Most common.
Yeah. Triggered by physical things, chemicals, biological agents at work. And often it's a mix of irritation and allergy, maybe on skin that's already a bit sensitive.
That work connection seems huge then. Okay, we've got the definition, the main types. Let's get into the causes. The etiology section in your notes seems packed with examples.
It really is. And the triggers fall into those two buckets, irritants or allergens. For ICB, the irritants you've listed are, well, everyday things often. Water, especially hard water or chlorinated water.
Just water. Wow.
Yeah, frequent exposure. Then detergents, soaps, solvents, things that strip oils, abrasives, machining oils, acids, alkalis. There's cement again, powders, dust, soil. Even some plants like ranunculus, spurge, mustards can be directly irritating.
It really makes you think about things like frequent hand washing, doesn't it? Seems harmless, but for some people.
Exactly. Constant exposure can be the issue. Now, for ACD, the allergens are also often things we encounter all the time. Cosmetics are a big one, fragrances, hair dyes.
Yes, fragrances.
Metals like nickel, super common, right? In jewelry, belt buckles, snaps on jeans. Chromate is another metal.
Nickel allergy must be responsible for a lot of cases.
Oh, absolutely. Then you've got topical medications. Your notes mention that interesting, though rare, possibility of being allergic to topical steroids themselves.
Which is wild because they're the treatment. That's a definite high-yield point.
Definitely one to remember. Other common allergens you listed, rubber additives like in gloves, dyes or formaldehyde in textiles.
So clothing could be a trigger.
Yep. Also, epoxy resins and adhesives, acrylics, formaldehyde and plastics and glues, and then plants again, but different ones this time. Chrysanthemum, sunflowers, daffodils, tulips, primula. These cause allergic reactions.
So literally from gardening to construction to just getting dressed, the potential triggers are everywhere.
Pretty much. And this leads into the associated conditions your notes mentioned. Sometimes contact dermatitis doesn't happen in isolation.
Like what?
Well, you might see contact urticaria. That's a faster hive-like reaction. Sometimes apnea or folliculitis, maybe from oils. Skin infections are a risk because the skin barrier is damaged,
Makes sense. Easier for bugs to get in.
right? Bacterial or fungal. Also, changes in skin color, mechanical damage, and even indirectly, skin cancer is mentioned in the context of known carcinogens like UV, radiation, or certain chemicals that might also cause contact reactions.
It just shows how interconnected skin health is. Okay, let's look at risk factors from your notes. Who's more likely to get this?
Your notes lay out the main ones clearly. First, a history of atopic dermatitis eczema. That's probably the biggest single risk factor, suggests generally sensitive skin.
Okay, atopic history. What else?
Occupational exposure, which we keep coming back to. Frequent hand washing, that direct irritant effect. Female gender is listed as more commonly affected. And finally, a personal or family history of allergies generally, hinting at that broader allergic tendency.
Those seem like really practical things to ask about. So we know what it is, what causes it, who gets it, what's the actual mechanism, pathophysiology. Your notes keep it concise.
Yeah, basically it's an inflammatory response run by immune cells. Key cells, dendritic cells, are the main players mentioned. For ACD, the dendritic cells grab the allergen, show it to the T cells, and the T cells launch the attack on re-exposure.
And for ICD.
It's more about that direct cell damage triggering inflammation, but immune cells still sort of pile in and contribute to the redness and swelling.
Okay, so inflammation is the end result, whether it's direct damage or a specific immune memory kicking off. Now, a crucial step, differential diagnosis. Your notes list things that could look like contact dermatitis. What else should be on the radar?
This is super important because rashes can look alike, right? Red, itchy, scaly. Your notes list the big ones to consider. Atopic dermatitis, common eczema, psoriasis, fungal infections like ringworm, and other types of eczema that aren't caused by contact.
So basically ruling out other common inflammatory or infectious skin issues.
Exactly, and there are others listed too. Seborrheic dermatitis, urticaria, though that's usually much faster onset.
Yeah, hives pop up quickly.
Right. Fixed drug eruptions, lichen planus, scabies, even acute infections like cellulitis impetigo, shingles. Chickenpox could be confusing in some presentations.
Wow, okay, that's a long list. How do you possibly sort through that?
Well, this is where the history and the pattern are just gold dust, as your notes emphasize. Where is the rash? When did it start? Did you touch anything new? Is it sharply defined or spreading? Those details are key.
Location, timing, pattern. Makes sense. Let's talk numbers. Epidemiology. How common is this in the UK, according to your notes?
Your notes give some good figures. Contact dermatitis itself affects maybe 10–15% of the UK population at some point. That's distinct from all dermatitis, which is around 20% because it includes atopic.
Okay, so a significant chunk of people experience it.
And it accounts for about 4–7% of all dermatology consultations. So, yeah, it's a big deal. Notes reiterate it's more common in women, often on the hands, less common in kids, but seems to be increasing. And those high-risk jobs, again, healthcare, engineering, food production, cleaning, beauty, petrochemicals, construction, farming. Your notes list them all. Really useful for occupational health context.
Knowing those sectors is key. All right, clinical features. What does it actually look like and feel like for the patient?
Okay, the typical picture described in your notes. Erythema, that's the redness. Pruritus, the itch. You might see vesicles or blisters. And if it's been going on a while, the skin can get thick, lichenified.
So red, itchy, maybe bubbly, and potentially thickened later on.
Exactly. The key symptoms listed are itching, usually the main thing, burning, swelling, redness, sometimes hyperpigmentation, darkening in chronic cases, scaling, and painful fissures or cracks, also typically chronic.
And the big clue you mentioned earlier, the location.
Absolutely critical and highlighted in your notes. The rash is generally where the contact happens.
So if you react to your watch,
the rash is under the strap, right? Your notes give great examples. Hands are super common. Clothing allergy. Look in the armpits, groin, feet. Dust often settles in the crooks of elbows, behind knees. Vapors or mists. Face and neck, usually.
Those patterns are so helpful diagnostically. Now, you said ICD and ACD often present differently. Your notes detail this contrast.
Yes, this is vital. With ICD, people often complain more about burning, stinging, soreness, rather than just intense itching. The onset is usually fast, minutes to hours. The rash boundary is typically sharp, like right where the irritant touched, and it tends to get better relatively quickly once you remove the irritant.
Okay, ICD. Quick, burning, stinging, sharp border, quick resolution.
Got it. Compare that to ACD. Here, it's often more about redness, intense itching, and scaling. The onset is delayed, could be 12 hours, could be 72 hours, even longer after contact.
Because of that immune lag time.
Exactly. And because those immune T cells can migrate a bit, The rash might spread slightly beyond the contact zone, so the edges are often less defined than ICD. It also takes longer to clear up, maybe weeks, even after you stop touching the allergen.
ACD delayed, itchy, less defined border, slower resolution. That's a really clear distinction from the notes. Though your notes do add that they can share features: redness, blisters, scaling, itch.
Well, for sure, there's overlap. But you look for the predominant symptoms, the timing, the pattern. Those are your best clues to figure out which type it might be.
Putting the pieces together. Okay, so you suspect contact dermatitis. How do you confirm it or find the specific cause? Let's look at investigations. Your notes say it's mainly a clinical diagnosis.
Primarily, yes. A good history asking about exposures and a careful look at the rash are often enough. But the key investigation, especially if you suspect ACD and need to know what the allergen is patch testing.
Patch testing. How does that work based on your notes?
So it's designed to pinpoint the specific culprits in ACD. You apply tiny standard amounts of common allergens and maybe specific ones suggested by the patient's job or hobbies onto the skin, usually on the back, under special sticky patches or trays.
Okay.
Then you check for reactions after about 48 hours and often again at 72 or 96 hours. A positive reaction looks like a little patch of eczema under the test spot. Your notes rightly say this often needs specialist referral, especially for tricky occupational cases, for accurate testing and interpretation.
So patch testing nails the specific allergen in ACD.
That's the goal. Your notes also mention skin biopsy. It's not routine for contact dermatitis, but you might consider it if patch testing is negative but you still suspect something, or if it's chronic and unclear, or maybe to rule out other things like psoriasis that can sometimes look similar. But most often, history and exam are enough.
History, exam, maybe patch testing, rarely biopsy. Got it. Right, the crucial bit. Management. How do we treat this?
Core principles from your notes. Number 1, identify and avoid the trigger. Number 2, use topical corticosteroids for the inflammation. Number 3, emollients to soothe and protect. And number 4, patient education.
Avoidance sounds like the absolute cornerstone.
It really is. If you can avoid the cause, you're halfway there. For prescribing, your notes say topical steroids are first line for both ICD and ACD. They reduce the inflammation, calm the itch.
Standard steroid creams, applied as directed.
Yep. For ICD specifically, your notes add: use moisturizers liberally and add steroids depending on severity. For mild to moderate ACD, if steroids aren't quite cutting it, topical calcineurin inhibitors like tacrolimus are listed as second line. They're non-steroidal anti-inflammatories. Phototherapy is also mentioned as second or third line for ACD.
Okay, so extra options for ACD if needed. What about really bad cases?
For severe ACD, your notes list oral corticosteroids, like a short course of prednisolone, as second line. And then for really tough, resistant cases, often managed by specialists, the third or fourth line options mentioned are more phototherapy or immunosuppressants, like cyclosporin or azathioprine.
Right, stepping up the treatment ladder based on severity. What about the non-prescribing side of things? General advice.
Beyond avoidance, can't say it enough, your notes highlight key stuff. If it's occupational, involve occupational health. Use the right protective gear, gloves, barrier clothing. Switch to fragrance-free soaps and washes. Use emollients and barrier creams like crazy. They help repair the skin barrier.
And that occupational link, again, your notes mention notifying the HSE in the UK and potential benefits.
Yes. Occupational dermatitis is notifiable, and people might be assessed for industrial injuries disablement benefit. It really underlines the serious impact it can have on work.
It does. Any other practical tips from the notes?
Yeah, a couple of good ones. Antihistamine tablets, generally not that helpful for the itch of contact dermatitis, surprisingly. Your notes advise against them usually. And take rings off before washing hands. Soap and water get trapped underneath.
Ah, the ring tip. That's a good one. And the specialist treatments for chronic cases, PUVA, cyclosporin, those are for when things get really tough.
Exactly. Dermatologist territory for resistant cases.
So what's the typical outcome? Prognosis.
Your notes stress, it really hinges on how bad it was initially, and crucially, how well the person can avoid the trigger.
Makes sense. Avoid the cause. It gets better.
Ideally, yes. Successful avoidance can mean resolution. But as your notes point out, that might mean changing jobs if it's work-related and you can't avoid it there. If the trigger is easy to remove, it clears quickly. If it's hard to identify or avoid, it can become chronic or keep coming back.
And if you've developed an allergy, say, to nickel, does that ever go away?
Key point from your notes. The sensitivity to allergens can stick around. Even if you completely avoid it for ages, the rash goes, but the immune memory is still there.
So touch it again years later and you could react again.
Exactly. And Comparing the two types, your notes say ACD generally has a worse prognosis than ICD unless you find that specific allergen and manage to avoid it completely. Poor prognosis is linked to really severe initial dermatitis and taking a long time to get diagnosed and find the cause.
So getting onto it quickly and finding the trigger is vital, especially for ACD. Your notes also touch on prevention.
Yeah, basically all about minimizing contact. Employers' roles, using protection, washing facilities, education, moisturizing, checking skin, using labels and safety data sheets, all the common sense stuff, really important in high-risk jobs.
Definitely. Prevention is better than cure. Lastly, complications. What can go wrong according to your notes?
Your notes list 3 main things. 1, secondary infections, bacterial or fungal. That broken skin barrier is an open door, can look like impetigo sometimes. 2, chronic or recurrent dermatitis if you can't fully avoid the trigger. 3, psychological distress. Your notes mention this, and it's important. Chronic skin issues, especially if they affect your job, can really impact quality of life, mood, self-esteem, potentially leading to needing to change careers, like we said.
Yeah, it's definitely not just skin deep. It can have really significant knock-on effects.
For sure.
Okay, well, that was a really thorough run-through of your notes on contact dermatitis. We've covered the definitions, causes, ICD versus ACD, diagnosis, management, outcomes, the whole lot.
Yeah, it's quite a journey from a simple itch to potentially using immunosuppressants or changing jobs. Really highlights the importance of identifying that trigger.
Absolutely. Which leads us to our final thought for you, the listener, building on all this. Your notes highlighted that sensitivity to an allergen can persist long after avoidance, and severe cases might force someone out of their job. So thinking about this really common condition, often sparked by everyday things, soap, jewelry, work materials, how often do we actually stop and consider the potentially huge long-term impact that contact dermatitis can have on someone's life, their work, and just their overall well-being?
It's a really powerful point, the hidden burden of something so common.
Well, thank you for sharing your excellent notes with us for this deep dive. We really hope breaking it all down like this has been helpful for your revision, or just for getting a better handle on contact dermatitis.
Hope so, too. Understanding these details really does matter.
And if you want more resources to help with your revision, head over to PassThemSRA.com.
And for free practice questions to put your knowledge to the test, check out freemsray.com.
We'll catch you on the next deep dive.